Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to a new presentation from Edu-PIC. I'm Ahmed Saudi, Pediatric Cardiology Clinical Fellow, and we are going to talk about POCUS echocardiogram. So today we are going to talk about the basics of echocardiogram, standard views, POCUS approach, function assessment, fluid status, pericardial effusion, and cardiac tamponade, also PDA. So first know your machine and choose the appropriate probe. So as we see, there is different shapes of ultrasound probe. Uh, and this is the shape of the cardiac probe. And even this cardiac probe has a different frequencies and different shapes as well. But simple as that, higher frequency has a better resolution but less penetration, and the probes with a lower frequency has a better penetration but less resolution. So we use it in the bigger children, and the higher frequency probe we use it in the smaller children and neonates. Then next we'll go through nopology, and so most of the machines has different layouts, but most of the machine have the same basics and same button. So here we have a power button. Then we have the different modes of ultrasound imaging. So we have a 2D image, color image, Doppler and M mode. Then we have here this button to create a video clip, and this to save your clip, freeze to review the current image, and then here to bring up the calculator if you need to do any calculation, and this is for caliber or just for measurements. And here you can review your saved study, the whole study, and here you can adjust the depth of the image. Then this you can adjust the quality of the images, and for example the brightness. uh, After you know your machine, so we go through the standard views, and if you can see here, there's a marker in the probe, so you can adjust your image according to this mark. We have four standard echocardiogram views. So we have subcostal view and apical view, parasternal, and suprasternal notch view. In PICU, usually we can use the subcostal, apical, and parasternal views. So let's start with the subcostal view. And when you move your probe up and down and left and right, the same different angles, this will cut your heart in different slices, and each slice give you some information. One of the important views in the subcostal views is an inferior vena cava view. So you can put your probe knob towards to 12 o'clock. It means towards to the patient's head, and the probe is a bit perpendicular. Maybe sometimes you need to make it slightly to the right. Then you can see the inferior vena cava, which is connected to the right atrium, and from this view you can assess the volume status of the patient. So when we rotate our probe clockwise from 12 o'clock to 3 o'clock, as we see the marker here towards the 3 o'clock and slightly anterior angulation, then we can see the four chamber subcostal view. So we have here the left atrium, right atrium, and interatrial septum. And to the left atrium, we have here the left lower pulmonary vein, left upper pulmonary vein and right upper pulmonary vein, and this is the left atrial appendage. And in the bottom here we can see the left ventricle with a mitral valve, posterior and anterior mitral leaflet, and here we have the right ventricle, and this is the interventricular septum. And further angulation to the anterior at the same orientation, 3 o'clock position of the probe, and more anterior we can see the left ventricle, and this is the right ventricle, with an interventricular septum, and we can see the pulmonary valve. And this is the liver in this side. Then moving to the apical four-chamber view, so the same idea with this different movement and different angles of the view, we can cut the heart in different slices, and each slice give us different information. So to obtain a good four-chamber view, so you will place your probe as you see in the image, and the marker will be towards to the left shoulder. And if you have bigger children or older children, may you need to put your patient on the left side. Then you can push the heart towards to the thoracic cage, then you can have a better image. So that we can get from the four-chamber apical four-chamber view. So this is the four-chamber left atrium, right atrium, and iterator septum. And this is the left ventricle, right ventricle. This is a mitral valve, tricuspid valve, and this is a interventricular septum. This is the descending aorta, and this is a right lower pulmonary vein. Then when you angulate from the four-chamber slightly anterior, you can get the five-chamber view. So five-chamber, you can see the aortic valve and the left ventricular outflow tract with a first part of the aorta, which is the ascending aorta. Then moving to parasternal views. So we start with the parasternal long axis. So you move the probe to the left angle, and as you see here in the image, uh, uh, but the knob we cannot see here in the image, but it will be towards the patient right shoulder. So we'll obtain this view. So this is the left ventricle, interventricular septum, right ventricle, and this is the aorta and LVOT. This is a mitral valve, posterior leaflet and anterior leaflet, and we have here the left atrium, and this is the ascending aorta with aortic valve. And here to obtain the short axis view, parasternal short axis. So from the long axis view, we just rotate clockwise and make the knob towards to the patient's left shoulder again. Then you can obtain this view. So you cut the heart in the short axis uh, at the side of the mitral valve. So you can see here the right ventricle, and this is the left ventricle at the level of the mitral valve. Then this is a interventricular septum, and this is a mitral valve, and it has a characteristic uh, um, view, characteristic shape in this view, which like a fish mouth. So this is a anterior mitral leaflet, and this is a posterior mitral valve leaflet. Again, from the short axis view, when you change your angle orientation, then you can cut the heart from base to the apex in slices, and each slice give you a different piece of information. So this is another slice from the short axis parasternal view. So when you move a bit posterior from the previous view, so you can have a cut for the left ventricle at the level of the papillary muscle. So this is an anterior papillary muscle and posterior medial papillary muscle, and this is the interventricular septum, left ventricle and right ventricle. Then from parasternal short axis view, if we just move the probe uh, 2 or 3 intercostal space uh, to the clavicle, so we can see the ductal view. So we can see in this view the pulmonary artery, and this is the right pulmonary artery, left pulmonary artery, and this is a good view to assess the presence and the size of the PDA. moving to our suggestive approach. Um, First, rapid assessment of the global systolic function, assessment of the volume status, and evaluation of the inferior vena cava, evaluation of the evidence of epicardial effusion and any signs of cardiac tamponades, assessment of the patient response to resuscitation with a serial examination, assess the presence and the size of the PDA. So here the four-chamber view, quick assessment of the systolic function, and as we see here, this is a patient with a good systolic function, and this is some labels of the cardiac structure. This is five-chamber view. Here we have an example for patient with heart failure. So we on the X-ray we can see significant cardiomegaly. As you see, the cardiac shadow is quite big. And here we have a still image from echocardiogram with a dilated left ventricle and a dilated left atrium. So here we have a patient with a four-chamber view with a decreased cardiac function. So as we see, there's a significant dilatation of the left ventricle, and the interventricular septum is bowing to the right side, which make the RV cavity is small because it's compressed with a dilated left ventricle. And here from short axis parasternal view, so we can see the dilated left ventricle with a very poor contractility, and then we can apply the M mode, just pressing M mode, then we can have a further assessment for the cardiac function. So I'm trying to show here how should we obtain a good M mode image. So from parasternal long axis or from the short axis view parasternal at the cut of the level just below the mitral valve, so we can apply the M mode, so the line will cut the heart in this line, then have an assessment for the cardiac function, as we'll see in the next slide. So we can obtain the M mode from parasternal short axis or parasternal long axis. Here we can get it from the parasternal long axis just below the mitral valve. So we cut the heart at this line and we get this image. Then we can have some calculation and the machine will auto-calculate the ejection fraction shortening. So we should take some measurements here. So here the interventricular septum in the diastole, and this is left ventricle during diastole, and this is a posterior wall, and this is a left ventricle diameter during systole. So this is a different way to assess the systolic cardiac function. So for the left ventricle, we have a MAPSI. So this is a mitral annular plane systolic excursion, and the same concept applied to the right ventricle. It's TAPSI, so tricuspid annular plane systolic excursion. So simply we apply a mode at the plane of the mitral valve or tricuspid valve. Then we can have this view, and we can assess the distance between systolic and diastolic. So generally speaking, for MAPSI, 10 millimeter and above is considered as a normal, and for the MAPSI, for the TAPSI is 8 millimeter and above considered as a normal value. Then moving to assessment of the volume status. So from subcostal view at 12 o'clock, we can assess the IVC. So this is considered as an average size of the IVC. So if it's too much collapsed, too much thin, so that means that the patient is hypovolemic. And if it's significantly dilated, which is not changing with a respiration by the M mode, this means that the patient is overloaded. But this sometimes can be misleading with a patient who is ventilated because they have some positive pressure and make the respiratory variation is a bit less. So generally speaking, again, if the respiratory variation for non-ventilated patient is 50%. So that means the collapsibility of the IVC is acceptable and there is no signs of overload. And for ventilated patient, there's some studies showing that maybe 25% change in the collapsibility can be normal for these patients and not a sign of volume overload. How can we assess the presence of the pericardial effusion? So from parasternal short axis view, as we see from the normal images previously, this part is considered as a pericardial effusion, and also this is from the apical four-chamber view, and this is from parasternal long axis view. So you can see this part. This is some separation between the pericardial and the adjacent organ, so which is filled with some fluids. So this goes with a pericardial effusion. So here we have an example for the patient with a pericardial effusion. So this is the pericardium and this is the heart, and this is some fluids lying between the pericardium and the heart. This is a pericardial effusion, which it's surrounding the heart. It's considered as a moderate size pericardial effusion. And in this image, we can see the heart floating in the big pericardial effusion. This is from the parasternal short axis view. So this is the left ventricle and this is the right ventricle, and the heart is floating in the big pericardial effusion. In this images, we can see some signs of cardiac tamponade, so we can assess if there is a pericardial effusion which can cause a cardiac tamponade. So first, you need to assess the patient clinically, and then on the echo, there is some signs of cardiac tamponade. So one of them is involution of the right atrium during diastole, so it's a compressed involuted inside the right atrium. This is a sign of the increased pressures outside of the heart, and then this is again could be a sign of cardiac tamponade. Also in this image as well, we can see the indentation uh, of the right ventricular wall is compressed by the effusion, which can cause hemodynamically instability and cardiac tamponade. Here we have another example with a patient with a cardiac tamponade, but he has a big thrombus just compressing the right atrium. We cannot really see the right atrium properly in this image, which has been compressed by this thrombus, which can causing the cardiac tamponade, and this patient needs a pericarditis or intervention as soon as possible. We have a quantitative method to assess the presence of cardiac tamponade. So it's not only related to the amount of the volume surrounding the heart, but also the hemodynamically significance of this pericardial effusion. Um, so we apply a Doppler mode at the tricuspid valve, and we can assess the uh, respiratory variation. So if the variation is exceeding more than 40% between the highest and the lowest wave, that means the patient is in cardiac tamponade. And the same concept, you are doing this in the LVOT, in the five-chamber view. That's why we need to know how to get the five-chamber view. And if there is any respiratory variation between the highest and the lowest peak exceeding more than 25%, this is also a sign of cardiac tamponade. So please note, sometimes the pleural effusion can be mistaken with a pericardial effusion, and one of the ways that you can differentiate between them is try to find the descending aorta in the four-chamber view. If the fluid is behind the descending aorta, this is most probably is a pleural effusion. But if the fluid is lying in front of the descending aorta, this is most probably is a pericardial effusion. Then finally, from POCUS, we can assess the presence of the PDA, especially with the neonates and a patient. We suspect that they are duct dependent. So we see if this patient has a PDA that needs to be opened, starting some medication. So we can get this from high parasternal short axis. We can see the pulmonary artery and the right pulmonary artery and the left pulmonary artery, and usually the flow is coming away from the probe, so it could be blue. But the PDA, if it's from different to flow, is going to be in red. So we can see this red flow. This is the PDA. And here we can see the different size of the PDAs. Um, so in this one, this is a small jet or small color here, and this is a slightly larger. So this is a medium-sized PDA, and this is a big size PDA. As you can see, the red color is a bit wide in comparison to this one and this one. So finally, POCUS echocardiogram provides us with a real-time dynamic assessment of the cardiac function. So it can give us an idea about the ejection fraction, fraction shortening, eyeballing of the cardiac function, response to the treatment, and also fluid status and pericardial effusion, and if there is any signs of cardiac tamponade. In addition to uh, PDA assessment size and presence, especially in neonates. It's a rapid and sensitive examination, but it needs more practice. So please be familiar with your machine and practice the approach. And if you have any concern, you need to discuss with a cardiologist if there is a need to do a more detailed scan. So please, if you have any questions or comments, please send it to our group on the Facebook or comment on the video on this video on our YouTube channel. Thank you very much.